Hi guys, welcome back. We shall be now talking about alcoholic hepatitis. I'll begin by saying that a very paradoxical statement that I'm making before you is that only 10 to 20% of alcoholics will actually end up with development of alcoholic hepatitis. Now, why is that so? We are really not able to explain. But the surprising thing is that alcohol is the third largest disease burden in the world after coronary artery disease, diabetes mellitus. Alcohol and alcohol related substance abuse contributes to the third most common disease burden, but only 10 to 20% of alcoholics will end up with development of alcoholic hepatitis, and this is probably related to the amount of alcohol intake. So if in the exam they ask you that how much alcohol intake will contribute to development of alcoholic hepatitis, then your answer would be as follows. For a male patient, between 40 to 80 grams of alcohol per day is the one which is responsible for development of a fatty liver. Remember my words, fatty liver. And if he says the word 160 grams per day, then 150 grams per day is the threshold for development of alcoholic hepatitis. And then obviously the next equivalent to that would be development of cirrhosis in the liver of the patient. So though alcohol is being used, I would say on a large amount recreationally by youngsters, I mean binge drinking, you can see that it is mostly people who have just started earning. They are the ones who are binging of alcohol, and I have explained to you the surprising statement of sudden cardiac death, especially in alcoholic with respect to holiday heart syndrome. I have explained that these patients could be dying because of development of atrial fibrillation. But today we are talking about a different context. What I mean is we're not talking about the heart involvement, but the liver involvement in the patient, and therefore dose dependent damage in the liver is to be remembered by you. In the exam, if he says both 40 and 80, mark it as 80 for fatty liver, and for alcoholic hepatitis mark it as 160. When it comes to females, a very surprising observation is that as little as 20 grams of alcohol per day is sufficient to contribute to development of alcoholic hepatitis. So women are more susceptible. Why is that so? That's again a matter of speculation, though I would say that the body mass index in females will be relatively lesser, the weight would be also lesser, so alcohol will be tending to considering the body mass being lesser, per unit the amount of alcohol in the body would be relatively more. But still that does not explain why the liver is affected at a lower dosage in females. Maybe it has to do something with hormones, but Harrison doesn't make any conclusive statement regarding why females are having it. Alcoholic hepatitis at a lesser dose of alcohol, almost I would say less than half of what it occurs in men. Then concomitant factors like hepatitis C, concomitant factors like genetics, and most importantly nowadays presence of non-alcoholic fatty liver disease with respect to obesity also increases to the incidence of development of alcoholic hepatitis. So with these three you will see a faster progression to alcoholic hepatitis in a patient. If we do a liver biopsy, though I think initially with alcoholic hepatitis, when we start studying in pathology, they give you a very classical description of alcoholic hepatitis. That's the slide that I'm talking about, a very classical one. You can notice that in this slide you can see macrovesicular fat deposition. You can see the big droplets of fats. So macrovesicular fatty deposition is a very characteristic feature that can be seen. Second that can be seen is neutrophilic infiltrate. Where this arrowhead is present, that is where the neutrophilic infiltrate is present. So just write the word PMN, the neutrophils which are present. And then is presence of Mallory hyaline bodies. Mallory hyaline bodies, well, what are they? They are eosinophilic deposits which would be found inside the hepatocytes of the patient. So if you read these terminologies, especially Mallory hyaline is obviously a dead giveaway, but if he gives you image based question, you should be able to pick up the eosinophilic inclusion of Mallory hyaline inside a hepatocyte, neutrophilic infiltrate present, and macrovesicular fat deposition. Then these are all findings which are in favor of alcoholic fatty liver developing in a patient. This is another slide which is highlighting before you the presence of Mallory hyaline bodies inside the ballooned hepatocytes, or subsequently they would even be a ballooning degeneration or spotty degeneration of the hepatocytes, and the fat is obviously washed off in the slide, so macrovesicular fat deposition. As far as causes of Mallory hyaline bodies are concerned, though I think the pathology teacher has done his job, I'll just quickly make you practice Mallory hyaline bodies and conditions where it can be seen. So one is obviously Indian childhood cirrhosis. What do you mean by the word Indian childhood cirrhosis is that if you're driving on the highway in India, you will see that poor people who live on the roads in shanties, they don't use stainless steel utensils like you and me. They use those brass utensils or copper utensils. And copper utensils, if used, like if the milk is being boiled in a copper utensil or water is stored in the copper utensil, then copper will go inside the body and that will contribute to development of Indian childhood cirrhosis in an individual. Then will be Wilson disease, very characteristic copper toxicity that causes Mallory hyaline bodies. Then can be primary biliary cirrhosis, which is related to a autoantibody, that is anti-mitochondrial antibody. Then is the topic of our interest, that is alcoholic hepatitis. And last but not the least, non-alcoholic steatotic hepatitis or NASH could be associated with Mallory hyaline bodies. So Mallory hyaline bodies are present in the following situations. The mnemonic for this from my side will be I will break alcohol status. So I is Indian childhood cirrhosis, W is Wilson disease, break is primary biliary cirrhosis, B, and then alcohol is alcoholic hepatitis, and alcoholic status, and status would be S of NASH, that is non-alcoholic steatotic hepatitis. So these are some of the important causes for Mallory hyaline bodies that you are already familiar with. Based on this, now let us look at how the patient will present to us. In alcoholic hepatitis, most patients are either asymptomatic or they will present to you with right upper quadrant pain. I am assuming the fact that the patient is coming to me with RU, right upper quadrant discomfort. I initially thought that he could be having cholecystitis. Initially, I thought that he could be having a tender hepatomegaly or viral hepatitis, especially because it can be associated with nausea and vomiting. But jaundice is usually not seen, so it's unlikely that you will mistake this guy to be that suffering from a viral hepatitis, but you would still keep your guard on, and initially you might get a basic liver function test done in the patient which may not show any significant findings, or maybe a bit of enzyme derangement that might be overlooked by you in the first go. But the moment he says that I'm an alcoholic, then obviously it will catch your attention that you need to look at the SGOT values, which are grossly elevated in the patient. In later stages, if there is a portal hypertension developing, then diagnosis becomes, I would say, a piece of cake for you, because you will notice then findings of splenomegaly developing in a patient, or they could be development of caput medusae in a patient, or a variceal bleed in a patient. But my objective is to pick up the patient before he actually gets into, that is, the portal hypertension state. So let's look at the workup of a patient who has admitted to being alcoholic and has presented to me with the right upper quadrant discomfort. When I will get the LFT of the patient done, one of the characteristic features that I will notice will be that the AST of the patient, that is SGOT of the patient, will be showing almost a 2 to 7 times rise. This is the main reason actually why we're discussing this topic, because biochemistry people are casually mentioned that gamma GGT is one of the parameters for diagnosis of alcoholic hepatitis. Actually, Harrison says different. Harrison categorically mentions that SGOT is the most specific test for development or identifying an alcoholic liver disease, whereas for viral hepatitis obviously it is SGPT, and for obstructive jaundice it is serum alkaline phosphatase, but here it is SGOT that is to be considered. In these patients, serum alkaline phosphatase can be slightly elevated but never a gross elevation. Like in obstructive jaundice, you will have almost 4 times elevation of serum alkaline phosphatase. In this case, you will not have a 4 times elevation. Maybe a doubling could be present in the patient. So LFT of this patient is gonna reveal a anectric hepatitis to you. Why I'm saying anectric is because there's no jaundice, but yeah, the enzymes of the patient are deranged, so I'm using the word anectric hepatitis in the patient as a presentation. On ultrasound, you will scan the liver echo texture. And obviously in the later stages you will also pick up presence of portal hypertension in a patient, but initially it is the echo texture that would give away. Later stages, portal vein flow reversal, development of ascites are pointers, but early identification is based on liver enzymes and ultrasound. If you will do prothrombin time in the patient, because liver is getting damaged, the prothrombin time will be deranged, because normal prothrombin time is 11 to 15 seconds, and in patients who are having alcoholic hepatitis, PT is increased. Albumin in early stages can be normal, but in the later stages will definitely get reduced. So when you are doing these tests in the patient, you are obviously, you can do a KFT also later, because hepatorenal syndrome, even the kidney can get involved if the liver is getting deranged, but obviously in initial part serum creatinine would be normal. So my objective as a physician is that I want to pick up this particular disease relatively early, and therefore we have two statistical informations to be remembered. One to be remembered is called as discriminant function or discriminant score. There are two main reasons why I have gone into this lecture. One is to highlight the fact that the best test for diagnosis of liver disease in a patient is not gamma GGT, and it is SGOT. And second is to highlight regarding discriminant function or discriminant score, on which questions have been asked. The formula here is 4.6 times into the increase of prothrombin time above the control. What I mean by above the control is, like, let me say the upper limit of the control is 15 seconds and the actual PT of the patient is 30 seconds. So it is 15 seconds higher than what is the control. So I will in this formula put up the value of prothrombin time, how many seconds it is more than the upper limit of the control. And in these patients, I'll be adding the value of serum bilirubin. And in these patients, you will notice the fact that if the discriminant score of the patient turns out to be more than 32, that is definitely an indication for starting treatment in the patient. Model for end-stage liver disease, MELD score in the patient if more than 21 is again an indication for indicating or starting treatment in this particular patient. The parameters of the MELD score to be remembered are bilirubin, though I mentioned them earlier in one of another lectures, bilirubin, INR and serum creatinine. So he says that you can evaluate the patient both ways, but he recommends a discriminant function or a score. Sometimes he might prefix the name of the doctor who developed this discriminant function, that is called as Madry's discriminant score, or you might just write the word Madry's score. So you just need to keep the attention on that. That basically means the same as discriminant function, and values more than 32 is an indication for going in for treatment, not the word liver transplantation. Remember, we are studying alcoholic hepatitis, not alcoholic cirrhosis. That's why I've gone into this topic, and I'm gonna now talk about what is now given in the textbook as Glasgow alcoholic hepatitis score. So one we study about Glasgow score, but a Glasgow alcoholic hepatitis score is the one which is to be remembered. Let's look at the parameters. Bilirubin and prothrombin time are always gonna be present in every liver disease scoring pattern. I mean, whether you look at the MELD score, you look at the PELD score, you look at the Child-Pugh score, in every one of the scores, including Mazur's index for Wilson disease that talked about bilirubin and prothrombin time, will always be there. The extra things which are to be remembered here are A, B and W. What I mean by A is the age of the patient, B is blood urea nitrogen, and W is the white blood cell count. And Glasgow alcoholic hepatitis score is a new parameter which is given, so they can ask you about the parameter components. Remember, standard, that is bilirubin and prothrombin time. The extra thing is ABW, that is age, then is the blood urea nitrogen values and the WBC count of the patient. So that's another scoring pattern that you need to remember to identify alcoholic hepatitis in a patient. This time I am showing you a Harrison table. Why I am doing that is, one, because I want to point to the fact that if the question is asked as what is the most specific liver function test, then the most specific liver function test to be answered by you is SGPT. Do not answer SGOT, because SGOT is present in cardiac myocytes also. So if SGOT is elevated, it could either mean the fact that the liver is damaged, or it could mean the heart is involved. But SGPT elevation would always mean the fact that it is liver that is damaged. So one, remember SGPT, which is also called as ALT. The alternative name is ALT, is the most specific liver function test. But when it says alcohol, then for alcohol the answer would be given as AST ALT ratio more than 1. If the ratio word is not given, then it is AST, that is SGOT. So I repeated, for alcoholic hepatitis it is SGOT and AST, which is the predominant one, and otherwise for routine liver function test the answer is ALT or SGPT. Gamma GGT, I agree that though you might have been taught in basic sciences like that, Harrison says totally opposite. It says not specific to alcohol and can be elevated in any forms of fatty liver, and obviously there are so many causes of fatty liver, including even obesity can be related to fatty liver, kwashiorkor can cause fatty liver, Reis syndrome can cause fatty liver. So we cannot be specific for only alcohol, gamma GGT being used for alcohol. Since you have already studied these aspects in other subjects also, and I was getting queries on like whether they should answer gamma GGT or SGOT, I thought I should show you this particular slide. Now is the treatment of our patients. So for treatment of alcoholic hepatitis, alcohol abstinence is of paramount importance. You have to put the patient on alcohol de-addiction program. You have to make him sign up for alcohol de-addiction program of your hospital. If he says what is the best drug for alcohol de-addiction, that would be naltrexone and acamprosate. Alcoholic has to be motivated enough to leave alcohol immediately. He should be like, that doctor, you have told me that I am having damage to my body by alcohol. So, you should pump him up so much that he should be ready to listen to you and sign up for a de-addiction program. And obviously, he has to be off alcohol. Only then the progression of damage can be prevented and you will start him on prednisolone. There are two molecules, one is prednisone and second is prednisolone. So prednisolone I'm talking about, that is 32 milligram per day for total of 4 weeks, is to be prescribed for these particular patients to reduce the damage in the liver of the patient and prevent the progression to cirrhosis. If a person is responding to prednisolone or not, even for checking that, there is a scoring pattern that is called as Lilly score. So just remember that Lilly score is not for diagnosis of alcoholic hepatitis. It is for response. It is for response to steroids. It is to gauge whether person is responding or not, or gauge the response to steroids in AH, alcoholic hepatitis. Recent studies have shown that tumor necrosis factor alpha also plays a role in alcoholic hepatitis. So they have developed a drug which can basically neutralize the production of tumor necrosis factor alpha, and that is gonna be pentoxifylline, and that is why you will see so many physicians writing not only prednisolone but even pentoxifylline to patients of AH, that is alcoholic hepatitis. I want to highlight the fact that the biggest paradox is that only something in the range of 10 to 20% patients who consume alcohol regularly, heavy drinkers I'm talking about, they tend to develop alcoholic hepatitis. You can see the figures here that the incidence of alcoholic steatotic hepatitis ranges between something in the upper limit of 20%. And reason I told you, why don't all develop it? It is dose dependent. More is the alcohol intake taken, that is when the damage in the patient would definitely be occurring. So do remember the fact that we are gonna prevent the conversion to cirrhosis, because if cirrhosis will occur, then you will have to do some tests. So I'm also using this opportunity to mention before you some non-invasive methods of assessing hepatic fibrosis and cirrhosis, which would be a sequelae of alcoholic cirrhosis, and you all know that alcoholic cirrhosis will then contribute to development of portal hypertension in the patient. So one of the tests or one of the non-invasive methods is a statistical formula that is called as APRI. Well, what does APRI stand for? APRI stands for AST2, platelet ratio index. PR is platelet ratio index. The values are in front of you, but you don't need to remember the values. Just remember APRI is a non-invasive method of assessing liver damage, that is AST2 platelet ratio index. Then is ELF, that is enhanced liver fibrosis panel. This enhanced liver fibrosis panel would be considering or containing 4 tests, that is age, then data of hyaluronic acid in the blood, then MMP3 is metalloproteinase, and TIMP, that would be a inhibitor of metalloprotease. This would be TIMP I'm mentioning here. This is a tissue inhibitor of MP, that is metalloproteinase. So these are all involved in damage to the liver, so are technically being evaluated. And apart from obviously these fancy names like FIB4 would include age, AST, ALT and platelet count. So you can see that AST, ALT are coming everywhere in the liver, including the platelet count of the patient. And yes, this is the main reason I've gone into the discussion, transient elastography. So nowadays you really don't need a liver biopsy, but even with help of a ultrasound beam, we can find out whether there is a definitive fibrosis developing in a liver damaged patient or not. So transient elastography is a test that is being regularly done. The brand name for this would be like FibroSure. Is regularly being done to identify the damage in the liver of the patient. And ARFI, that's another term, that is acoustic radiation force imaging. These would not be, I would say, any particular MCQs, but they could be just one of the choices in a MCQ of alcoholic hepatitis. That is, he could say that a non-invasive method to identify the damage to the liver caused by long-term alcohol intake can be. Then answer mostly will be imaging modality, because I'm talking about the imaging modality to be remembered would be transient elastography. It measures the speed of the shear wave generated by vibration to the liver tissue. That's more of physics, I would say. But yes, if there is fibrosis, acoustic waves will respond in a different fashion as compared to a normal echo texture of the liver of the patient. The salient features to be remembered from this discussion would be: one, to identify alcoholic hepatitis on a slide. Second would be to pick it up on discriminant score value, that is 4.6 into increase in the prothrombin time plus value of albumin if more than 32 or MELD score more than 21. And the DOC for alcoholic hepatitis is steroids. If he says alcohol de-addiction, then the answer is naltrexone and acamprosate for the patient. These are the details for this relatively simple topic. Thank you so much. And I highlight once again, SGOT is the best test to identify the SGOT SGPT ratio. Obviously, if not given, SGOT is the best one for identifying alcoholic hepatitis. So thank you so much guys, and keep the queries coming. Thank you so much.